guys, welcome back. Patient assessment part 2. We're going to be going over our secondary medical and our secondary trauma along with our reassessment. So we've already gone over our scene size up and our primary assessment, our history taking. So after the history taking, we really need to verge off into two different categories, one being our secondary medical or our secondary trauma. We're going to do about the same thing on both of them. We're just going to have a little bit different approach. Okay, so our secondary assessment. By the way, I'm starting off on page 625. So our secondary assessment, everything is based on facts or what we can see. This is also known as the physical exam. So when we do this, we really need to look through the patient. If you're looking at their chest, get down, go. Okay, fine. If you're looking at their chest, you need to look at their heart, their lungs. If you're looking at their abdomen, you need to know what's in the right upper quadrant compared to the left upper quadrant. So where do we start with this? So it should always be a systematic approach. However, the actual start is determined by several factors: stability of the patient, chief complaint, history, communication ability of the patient. A multi-system trauma patient will require your full head to toe, but if it's a medical patient with just one complaint or a non-significant MOI, we may just focus on that injury. So when we first get there, we need to figure out the location of the exam. Are we in a busy highway and we need to get them off of that? Are we in a bedroom where everything's quiet? Positioning of the patient and the patient's point of view. So what do you think the patient feels like where they are? Also, are they going to be comfortable where they're sitting or standing the entire length of your assessment? So some assessment techniques. Inspection we already went over. This is what you can see. Palpation is what you can feel. But a new one to us is percussion. This is just gently striking the surface of the body. You know, usually put your two fingers here and then hit your two fingers over different organs of the body. The high-pitched sounds are air, and the low-pitched sounds are usually fluid, blood. High pitch is your hollow organs, low pitch is your solid organs. And then auscultation, again, what we can hear with our stethoscope. So our vital signs, pulse, again, radial for responsive and carotid for unresponsive. We need to get the rate, presence, location, quality, and regularity of the pulses. So here's where we need to get our numbers. The presence or absence. So different pulse sites have different blood pressures associated with it. So if they have strong pedal pulses, they have a really good blood pressure. So we need to take location of all of the pulses. Respirations, again, get your number here. And we also want to know any accessory muscle use, shallow, deep, rapid, regular, irregular, blood pressure, pulse ox, temperature. Okay, some equipment used. Where am I? Sphygmomanometer, that's a good one. Blood pressure cuff, stethoscope, capnography, glucometry, ophthalmoscope to look in the eyes, otoscope to look in the ears, and a reliable light source such as a pin light. Okay, so the full body exam, also known as the physical exam, this includes looking and feeling of your patient. So really here we're looking for any hidden injuries. It's a systematic head-to-toe exam, just like the rapid exam, both looking and palpating. So this is used on our unresponsive or our multi-system patients. This is really going through in about 60 to 90 seconds and just rapidly identifying any issues and any hidden injuries. Gosh, that's difficult. So the focused assessment. This is done on our patients with non-significant MOIs. This is the immediate problem at hand. Once again, the little lady that fell off the curb or broke her ankle on the curb didn't actually fall. We can really focus on that ankle. Any respiratory, head, cardiac, abdominal issues, we can really focus there. Oh, look. Head, heart, lungs, abdomen, and any focused trauma. So the first thing we really want to look at is our mental status, and this is on page 635. So for any patients with a head problem, so they have a headache or altered mental status, or again, our unresponsive patient, we want to look at their ability to use reasoning. Again, we're going to look at the AVPU. If we're looking at their alert and oriented, whether they know where they are, who they are, person, place, time, and event. And one of our most reliable is the Glasgow Coma Scale. Remember that a rock actually has a GCS of 3, and our maximum is 15, with eyes being a 4, verbal being a 5, and motor being a 6. So word of advice, I would go ahead and memorize this scale right here. So when we're looking at our patient's mental status still, we want to look at their general appearance. So do they look like they know what's going on? Do they have any facial drooping? Do they note your presence and can they talk to you? We want to look at their posture. Are they supine? Are they decorticate? Are they decerebate? How are they sitting? Their facial expressions. Are they grimacing? Excuse me. Is their face relatively immobile? Are they blinking at all? There may be some Parkinson's disease if they don't blink and they just stare at you with no real facial expression. So their speech and their language patterns. Do they have ataxia where they can't actually speak? Their language patterns, can they hold a conversation with you and have correct language? Their mood. Are they happy when they really shouldn't be? Or are they crying or upset when there's no reason to be crying or upset? We also want to look at their insight and their judgment. Are they doing something that is probably going to hurt them without realizing it? And their attention and their memory. What I like to do is I like to tell a patient, hey, remember that I told you the number 3. So remember this number, 3. And about 5 minutes later, I'll come back and say, what was that number I told you again? And see if they can remember that. So skin, hair, and nails. So with the skin, we want to look for color. Are they pale? Are they cyanotic? Do they have mottling? Ecchymosis. And remember that ecchymosis is blood pooling, but it's not quite a bruise. A bruise develops over time. Ecchymosis is more like a pooling of blood immediately after the event. So this person was actually hit by a truck, and you can see the ecchymosis in the shape of the guardrail. So that's pretty impressive. Also, you want to look at the moisture of their skin, the temperature, the texture. Is it dry? Is it does it feel very thin? That could have some type of endocrine issue. And then their turgor, or also tinting. This isn't great on pediatric patients. The people who it's actually pretty good on are your elderly patients. So if you take your hand and bring this top of the skin up and let it go, if it stays up there, that is a sign of tinting, also a sign of dehydration. Just off the record, that's also how you assess dogs. for dehydration, right between their shoulder blades. So their hair, we want to look at quantity, distribution, and texture. Basically, all of those are leading us towards endocrine issues. The quantity, though, can also lead us towards any cancer if they've been going through chemo. Excuse me. All right, nails. We want to look at the color, the shape, and the lesions. So one thing that you can look at on people is the color of these two fingernails. If they are yellowish brown, that person's probably a smoker. Also, are they a pink color? Are they blue? We also want to look at the shape of them. So if you look at this picture here, this person has clubbed fingers, and clubbed fingers are a sign of long-term hypoxia. So if your patient has been born with some type of respiratory disease and has had long-term hypoxia, they're going to have clubbed fingers. So your patients that have cystic fibrosis will usually have this. Also, any lesions or striations. So if you also look at this one, you can see the striations on there. And that has some calcium issues and some endocrine issues. So after we do their mental status, looking at the head, we want to palpate the entire head. So if you find any depressions on the head, don't go pushing on them. That's a bad thing. So we also want to look for any blood or CSF. We want to look for any scars or shunts. And if you find a shunt, it's usually back here on the back of the neck. You can ask the patient where it drains to in their body. You'll get more into that in medical. Oh, also the anterior fontanelle on those younger than 18 months, so the soft spot on the baby's head. If it's depressed, it's a good sign of dehydration. And if it's bulging, could be a sign of overhydration or ICP. The eyes. Let me find myself. Okay, so the eyes. So first we want to start by palpating the lower orbits from the nose working outward. And we also want to check for visual acuity. So some things that we're looking for is diplopia, which is double vision, photophobia, which is light sensitivity, any blurring, discharge, or corrective lens use. And we also want to note that periorbital ecchymosis, so looking around for any raccoon eyes. Another thing to check for is, are they seeing spots in their field of vision? So the next thing we would want to check for is check the pupils for pearl. So pupils equal, round, and reactive to light. So the pupils should both be the same size. So if one is dilated and one is blown, that's a bad thing. We want both of the pupils. Sometimes you can note that one of the pupils aren't round, also a bad sign. And know that if you put light in one eye, the other eye should do the exact same thing. So they should both constrict. With that being said, when you're doing this, don't go from side to side because it won't give the eyes time to adjust. Actually take it and move it around and over, around and over. We also want to make sure that the patient can track movement. So what I like to do is start over here and have them track here. This takes it from side to side and up and down. Then we want to examine the eyelids and any of the surrounding structures. All right, so ears and nose. On our ears, again, the beginning of this is an A&P review, and I don't want to go over all that. So we want to check for any abrasions, lacerations, blood, or CSF, and we check for that blood or CSF by the halo test. So this is actually a patient's pillow, and they had gotten hit in the head. You can see the halo test around it. So all that clear stuff would actually be CSF with the blood in the middle. We also want to check for any hearing issues. You should now be able to know if they have any major hearing loss, but the best way to do it is to put your hands behind the patient's field of vision and snap and have them say which side it's coming from. Also, we want to assess for battle signs, which are the bruising behind the ears. We also want to check the nose for any issues. Anteriorly and inferiorly, we want to look for asymmetry, deformity, wounds, foreign body, bleeding, or tenderness. That's easy. Know that our pediatrics are primarily nose breathers. So if their nose is clogged, they will not be breathing correctly. We need to suction that out. All right, moving on to the throat. Just know that the throat also consists of the mouth, the pharynx, the neck, lips, teeth, and oral mucosa. So on the mouth, you want to check for the color, any bleeding, any scratches. The pharynx, you want to check for any swelling. Neck, we want to check for JVD and any swelling. On the lips, swelling or lacerations, cuts. Teeth, make sure they're all there. And if they weren't all there, were they there prior to you being there? As in, did they just lose them or have they been gone for a long time? We also want to check the oral mucosa. I'm not saying you need to stick your finger up in the patient's mouth, but just kind of look and see if it looks like they're dehydrated. If it's really dry, they're very dehydrated. Also on your pediatrics, this is a good place to check for capillary refill. Okay, cervical spine. Blah, 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 all A&P review. So, when we're examining the cervical spine, we need to take into account the MOI. Is it a significant MOI to where there's a possibility of neck pain? We want to palpate, and if there's any pain during palpation, we want to stop that immediately. We want to check their range of motion. If the patient's neck is already hurting, do not do this test. But if they are not in any pain, actually you're going to help them out with this. You're going to take their head first and move side to side and front to back. Let them know that if there is any pain, we would immediately stop the assessment. So once you do it for them, they can do it themselves. Again, if there's any pain, they should stop immediately. All right, so the chest. I'm on page 648. We check the chest in 3 phases. First, we're going to check the chest wall. Then we will do a pulmonary evaluation and a cardiac evaluation. So when we check the chest wall, we want to look for symmetry. So first you'll start in the sternum, making sure that that is intact. And then you want to run your fingers or your hands down, pressing on all sides of the rib cage to make sure that you don't feel any crepitus. Also, when you're watching it, make sure one side or they both have rise and fall and there's no paradoxical movements. We're also looking for any retractions. So here or in between the ribs, we'll have accessory muscle use during breathing. We're also going to want to auscultate for lung sounds. With that being said, I'm going to put on these really stupid looking headphones so I can hear what's about to happen and we can talk about them. Okay, so our first one are bronchovascular sounds. These are soft, breezy, low-pitched sounds found at the mid-clavicular line. So these will be over the manubrium and over the main stem bronchus. So now our vesicular sounds. These are the finer, fainter breath sounds noted on the lateral wall of the chest. These are from those smaller bronchioles and alveoli. So those are both considered normal breath sounds. So the next ones we're going into are adventitious breath sounds. Sounds that aren't good, they may actually be pathologic for the patient though. So the first one is wheezing. This is an obstruction in the lower airway. So our next one is rales. These are wet breath sounds, usually indicative of cardiac failure. Sometimes they're difficult to hear, especially if you're in the back of a moving ambulance. Best place to check are on the back and lower lobes. All right, then you have bronchi. These are those congested breath sounds. They're continuous sounds, low-pitched rattling, indicative of fluid in the large airways, presence of mucus in the lungs, infections, pneumonia, inflammation. They're most prominent on expiration. They usually have a productive cough with it. Aspiration and fluids may also result in this sound. So our next one is stridor. This is a brassy crowing sound. You can usually hear this without a stethoscope. This is caused by narrowing, swelling, or obstruction of the upper airway. This could be epiglottitis, foreign body airway obstruction, or just swelling of the upper airway in general. Okay, so our last one is a pleural friction rub. These are squeaking or grating sounds when the pleural lining rubs together. We're going to hear these anytime the chest wall moves. Did you hear that grating sound? That sounds painful. Okay, I can take these off. All right, so with breath sounds, we also want to see if they are decreased or if they are absent. If they're decreased, are they decreased on both sides? Are they decreased altogether on one side? Are they decreased in just one lobe? Or are they absent altogether? Remember, we need to take immediate action to fix this if we do suspect a hemothorax or a pneumothorax. We also want to check for respiratory fatigue. We want to see if how long the patient's been working at breathing. So our next one, one way to check decreased breath sounds is the whisper test, and it's called whispered pectoraloquy. I'm guessing on that one. I really don't know how to say it, but I know how to do it. So basically, you're going to have your patient whisper the number 99 while you listen to those breath sounds. If you should be able to hear a muffled tone whenever they're saying 99. So I'm actually putting this back on so I can tell you right when they're doing it. So. I don't really need to tell you, you can kind of hear that. So if you can't hear that, or if it's very distant, that lung is probably pretty far away from the chest wall, and they probably have some type of hemothorax or pneumothorax. Okay, so let's continue with the chest, and we're going to go into our cardiac assessment. There's lots of things to do for the cardiac, but one of the things I want to talk about is auscultation of heart tone. I'm going to put on my stupid headphones again. Okay, so our normal heart tone here is S1 and S2. This is our normal lub-dub. the S1, S2. Lub, dub. Okay, so this is an abnormal sound in adults. So this is S3, and this is increased filling pressures. So do you hear that last loud thump after the S1 and S2? So this is S4. This is decreased left ventricular compliance or increased pressure in the atria. This is a lub dub dub. Lub dub 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 dub. So then we go into our Korsakoff sounds. This is our blood pressure sounds. So when we're taking a blood pressure, the first sound, of course, is our systolic, and the second sound is our diastolic. Brits, this is a whooshing sound over an artery. This is normally heard in the carotid artery. So if you put your stethoscope here, you'll hear like this whooshing going through every time that the pulse happens. So what's basically happening is there's so much plaque and just congestion in this artery that it's causing like an eddy. So in a river, if you have a tree and the water's rushing around it, behind it there is a circle of turbulent blood flow or turbulent water. This is basically what's happening in the artery. This plaque is causing eddies in the artery, and we're hearing this whooshing sound over usually the carotid. So heart murmur, this murmur that we're listening to here is actually a mitral prolapse, but you can hear that whooshing sound over the heart. Blood's just never really stopping, either moving too far forward or moving back with each contraction. So, with this, with our cardiovascular assessment, we also want to check the lower extremities. We want to look for any swelling or edema. This is how we're checking that ventricular system. See if we have any leaky capillaries. The best way to check for edema is just press on the shin. I know this isn't my shin, but press on the shin and let go. And if there's any indention left, they have some edema going on. We also want to check for JVD, jugular venous dissension, and this can be a sign of lots of things, and we'll go over some more of them in class. So again, check our lower extremities. We want to check for the pulses, any swelling, edema, color, any of that. We want to, again, look at the location, see if all of our pulses are present or if they're absent. Also, when you're feeling for the pulse, look for any lifts, heaves, or thrills. Basically, anything abnormal with their pulse. And we also want to check PMI. So the point of maximum impulse, this is where the base of the heart is actually going to be hitting the chest wall. So when you feel your heartbeat, that is your PMI, your point of maximum impulse. Okay, so let's talk about our pediatric cardiovascular assessment. With pediatric, cyanosis is our first sign of hypoxia. They become very cyanotic very quickly. This is normal following birth. If it's acrocyanosis, so the limbs, your arms and your legs may have cyanosis. This is normal for a little while following birth. In a child, S3 is normal with no other issues. So if they're having cardiac issues and you hear an S3, then it's not normal. But if you hear it and there's no other issues, we're good. So this should say a splitting S2 is common. Basically, that's things are happening on the right side a little slower than they are on the left side, and we'll hear that next. And their PMI is not always palpable, so you can't always feel their point of maximum impulse. So let me put these back on. So this is your splitting S2. You can hear that it's not a lub-dub, but it kind of draws out a little bit. So everything's a little bit longer because you're hearing two different sides. You're hearing the left side and then the right side. Okay, that's it for heart tones. Now, our abdomen, we are divided into 4 quadrants. We'll go through when we're in class and kind of talk about those 4 different quadrants and what's in them. But you've got your right upper, left lower, right lower. There are different types of abdominal pain. So the first one is visceral pain. Hollow organs are obstructed. These are going to be that cramping and diffuse pain. So they may have a small bowel obstruction or stomach, cramping, diffuse, widespread pain. And then you have inflammation. These abdomen wall may produce sharp, localized pain. This could be pelvic inflammatory disease or appendicitis. Lots of different reasons, but those are your 2 main ones. And then you have referred pain. Origin is in a particular organ, but you actually feel the pain somewhere else. So flank pain associated with kidney stones, inner thigh pain from appendicitis or inflammatory disease, scapular pain from cholecystis, or groin pains from renal. Different types of referred pain. So make sure we always inspect and palpate. We want to look at the shape, inspect and then palpate. So don't go pushing around before you inspect it. So look at it first. So orthostatic vital signs. This is a drop in blood pressure, usually more than 20 millimeters of mercury, from when a patient is sitting versus when a patient is standing. On the abdomen, again, make sure you have the patient point to their pain. If they can point to it, it's not radiating anywhere and it's not diffuse. Auscultation, percussion, and palpation. Quite honestly, auscultation is not really done in the pre-hospital setting. It takes a long time to hear bowel sounds, and it has to be very, very quiet, which doesn't always happen. So auscultation isn't a normal pre-hospital thing. Percussion, again, taking your fingers and hitting them. If your patient has ascites or anything like that, when you actually percuss it, you may be able to see waves of fluid through their stomach, which is really weird. And then palpation. Visualize the skin, the contour, and the appearance. So we'll go back to my ascites patient. These are your liver patients, and they have, they get those big round stomachs that you see. They're the ones that have to get stomach taps to get all that fluid off their stomach. But they will have, normally their body is really skinny, and then they just have this giant belly. It's crazy looking. So look for any of the following signs. So the Cullen sign is bleeding around the umbilicus, or Gray-Turner sign, which is bleeding, bruising around the flank. So your Cullen sign is indicative of, let me make sure I'm going to say this exactly like they say it in the book. Hold on. Well, if I could find it. Oh, no. Where colon sign. Indicative of intraperitoneal hemorrhage. Usually ruptured ectopic pregnancy or acute pancreatitis. So those are two big signs that we'll find on the abdomen. So then we want to describe the abdomen. Flat, rounded, bulging out. And I'm not just saying that they're overweight. This will be like your ascites patient. Ascites. Bowel sounds, again, not very commonly checked in pre-hospital. Palpations, guarding. This is when you're pushing, when you're palpating and they either suck in their stomach or they try and get away from you or they just grab your hand altogether. So continuing with the abdomen, first we need to look for rebound tenderness when we're palpating. This is a good sign of appendicitis. So if you are palpating in the lower right quadrant and when you push down, it's actually not going to hurt them, but when you let go, the vibration and the rebound from that is actually what's going to hurt them. That's a great sign for appendicitis, pancreatitis, or diverticulitis. We want to palpate the organs. We're going to go over how to do this in class, but try and palpate the liver and the spleen also. We want to look for any triple A's. So if you palpate on the stomach and you notice a pulsating mass, stop palpating, like immediately. We don't want to rupture that triple A. Hang on, my cat's coming up here to say hi to everyone. You can come say hi. Hi. Oh, careful. Hi. You want to come say hi? Just play with the microphone? Okay. So, quit. So we're looking for those triple A's. Once again, if you feel a pulsating mass, stop palpating it. And then we want to drive very, very carefully to the hospital after that. Don't hit any bumps. You don't want to rupture that triple A. So hernias, not really that life-threatening unless they're strangulated. At that point, basically, it sticks out all the time and blood flow stops moving to that portion of the organ. Did you want to come up here or not? So the female genitalia, when do we want to examine? Really, anytime there's any life-threatening hemorrhage, anytime there's any life-threatening hemorrhage, massive amounts of bleeding, then we'll examine. Imminent birth, crowning, all of that, then we should examine. Know that by examine, we mean look at. There is no reason to feel, touch, any of that. So where do we want to palpate? Basically, the palpation will take place above the pubic bone. We want to press on the ovaries and maybe those fallopian tubes, checking for ectopic pregnancies or anything along those lines. Where to inspect? Again, we never really want to place hands there. It's going to be more of a looking thing. Also, when to examine? If there is a female available to do this, the female is the person to choose. If not, then make sure your male partner at least has somebody in the room with him. So the male genitalia, when to examine? Really, unless there's some type of traumatic injury or massive bleeding, not going to examine. Again, use a male to do this. And if there's a female, at least have another person in the room with you. Where to palpate? Again, this is going to be above that pubic bone, bladder, anything like that. What to inspect? So we want to look for any discharge, bleeding, or swelling. We also want to look for priapism. Priapism, which is a spinal injury that's going to cause an erection, but that's caused because of the spinal cord issue. We also want to ask about STD testing. for males and females last time they were tested or if they've ever been tested. And erectile dysfunction for the males. Females too, actually, not for erectile dysfunction, but females and males can both take Viagra, and if we give them nitro when they're taking ED medication, it can cause a serious drop in their blood pressure. So the anus, again, when to examine, any major bleeding, life-threatening bleeding. What to inspect, again, we're just inspecting for bleeding, and anything that has gone up there, we're not going to put our hands in to inspect, but we're going to look and see if there's anything there. Bleeding, this can come from stools, so we really want to look for active GI bleeds, and if they have bright red blood, if they have charcoal-like blood, like that coffee ground emesis, that's going to lead us to think of an active GI bleed. Okay, so the musculoskeletal system. Let me get there. Got it. So we need to know the difference between a pathologic fracture from a physiologic fracture. Physiologic is when abnormal forces apply to normal bone structures. So physiologic, abnormal forces, normal bones. A pathologic is normal forces, abnormal bones. So pathologic can be, again, those osteoporosis patients where they just have such fragile bones that that any type of force, little bit of force, can break that. I used to transport a dialysis patient, and I saw her one day, and 3 days later I came back and she had 2 different casts on, and nobody had realized that she, just by lifting herself up in bed, she actually broke both of her arms, and they had been fractured for a while. So she also had osteoporosis, so that is the pathologic fracture. We also want to check for range of motion. Can your patient move everything? Can they move? Note their posturing. We'll go into that here in a second. So for the upper extremities on their posturing, we want to look for that shoulder squaring. So look in this picture here. Notice on his left shoulder it's nice and round and everything looks normal, but there on the right shoulder it's very squared off. That's telling us that he has a dislocated shoulder. We want to look at their elbow flexion and extension. So flexion and extension. We want to inspect the hands, make sure they can move everything. On our lower extremities, the best way to test this is to have the patient walk. However, that is not always an option, especially for our trauma patients. We want to look at their alignment. Check pulses. Oh, by alignment, so check out this lady's leg. We had always talked about closed femur fractures and how they were shorten and rotate. So that right there is a very good example of shortening and rotating. It may not be out, it may be in. Never know. And check pulses down there, make sure they still have pulses in those legs. So the peripheral vascular systems, when we're checking this, we want to start on the upper extremities. We want to start fingertips going up to the shoulder. So we want to look for any signs of poor peripheral circulation. So bluing, very cold, pale, and then does it just stop and go to a normal color, or how far up does that go? When we're checking the lower extremities, we want to check from the hips down to the toes. Again, looking for any color changes, any temperature changes, anything like that. On your hips to toes, we also want to look for any hot spots, any bright red spots. We're looking for DVTs. And rubor, this is seen in elderly patients. This is just bad blood flow. You'll also see this in a lot of your overweight patients. So in their lower legs, lower extremities, they're going to get that nasty red color where it just looks like blood flow is not happening to that leg. So look here on this picture, that looks bad. All right, going on to the spine. Inspect from two different ways. So first you want to stand right behind them and look at their spine, and then you want to stand to the side of them and look and see if their back is aligned correctly. So lordosis, this is where your spine is off and your lower back kind of way protrudes out. It can be very mild form or it can be a very severe form. This is a more severe form here. This is where you would want to inspect from the lateral position. Kyphosis, this is the spine up on the top. A lot of times this is from your elderly, your geriatric patients. One of the things that we need to recognize on this is when we are backboarding these patients, it's very difficult to backboard them. Our lordosis patients and our kyphosis patients. So you're really going to have to pad that backboard. And then scoliosis. This is curvature of the spine. This would be from the posterior position. Okay. So on the spine, when we run our finger down it, we want to use our thumb. So we want to use our thumb, make sure everything's aligned, make sure nothing's, poking out or they have no fractures of one of those processes. We also want to check their range of motion. Can they move side to side? Can they bend over on your, give me a minute, on your scoliosis patients. When they lean over, like to try to touch their toes, one side of their body is going to be higher than the other one. This is usually best done when the patient is supine, is what your book says, but not really sure how you're going to do that. All right, nervous system. I am all typed off on my tab order. So we want to check their reflexes. Using our hammer, if we can, see if they have those normal reflexes. We also want to check on our pediatric patients, those primitive reflexes. I went over that in the Chapter 9 lecture. On our neurologic exam, again, AVPU, we've already done that way back there. And they give this mnemonic of COAST-MAP. Quite honestly, never used it. You want to check for consciousness, orientation, activity, speech, thought, memory, affect, and perception. And then we also want to do a cranial nerve exam. So I'm going to play this video for you. This is the best way to do a cranial nerve exam. It does take a little while though. So I'm going to go ahead and play this for you.
Hello, my name is Dr. Berry. Do you mind if I examine some of the nerves in your eyes and your face today? Okay. First of all, can I start? Do you have any problems with your sense of smell or taste? No. No. Okay, and your vision, can you see the whole of my face?
Yep.
You can. Can I just test how good your vision is, if that's okay?
Yep.
So can I get you to cover one of your eyes? Okay, so ideally I'd have this 6 metres away. But can I get you to just read down from there for me?
X-U-A-H-T-Y-O, V-U-A-X-T, H-A-Y-O-U-X, Y-U-X-T-H-A-O-V, X-O-A-T, V-H-U-Y.
Brilliant. And can you swap eyes for me? And exactly the same, start from there.
X-U-A-H-T-Y-O, V-U-A-X-T, H-A-Y-O-U-X, Y-U-X-T-H-A-O-V, X-O-A-T, V-H-U-Y.
Brilliant. Okay, now keep looking in the centre of my face, and in the corner of your vision you're going to see my fingers moving. Can you point to which one that moves?
Both of them.
Okay, now I'm going to test your visual field. So can I get you to cover one of your eyes with your palm? Okay, and if you keep looking at the centre of my face, in the corner of your vision you're going to see my finger wagging.
Okay.
Say yes when you see it.
See it? Yes. Yes. Yes.
Okay, and let's switch eyes. Exactly the same thing.
Yes. 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 Yes.
Okay, now I'm going to test for your blind spot. Can I get you to cover one of your eyes, please? Okay, and can you see this?
Yes.
What colour is it?
Red.
Okay, I'm going to move it from one part of your vision to another. At some point it might disappear. Let me know if it disappears. Keep looking at the centre of my face.
It's gone.
Okay, tell me when it reappears again.
It's back again.
Okay, and tell me when it disappears again
It's gone.
and reappears again.
Back.
Okay, disappears again,
It's gone.
reappears again.
It's back.
Okay, brilliant. Let's do the same with the other side. Okay, can you see this?
Yes.
What colour is it?
Red.
Okay, so again I'm going to move it from one part of the vision to another. Tell me when it disappears.
It's gone.
Okay, tell me when it reappears again.
It's back.
Okay, and reappears. Disappears.
It's gone.
Okay, reappears.
Back. It's gone. It's back.
Okay, perfect. Okay, now I'm just going to test your pupils if that's okay.
Yep.
So I want you to just keep looking straight ahead in the distance for me. I'm just going to come up close with a light. It doesn't hurt in any way. Okay. Okay. Now can I get you to just look right at the distance?
Yep.
And now look at my finger. Okay, brilliant. Right, I'm going to look at the back of your eyes now. So I'm going to use this. I'm going to come very close. Bright light, but it doesn't hurt you in any way.
Okay.
So keep looking in the distance.
Yep.
Okay. Okay. Okay, and can you look towards me? And if you look up, look down, look to the right, and look to the left. Okay, brilliant. Going to do exactly the same, but coming in the different side. So keep looking in the distance. Okay, can you look towards the light, please? Okay, and can you look up? And look down. And look to the right. And look to the left. Okay, brilliant. Okay, now I'm going to test the movements of your eyes. So I want you to keep your head still, but just using your eyes, follow my finger. Tell me if your vision's blurred or double at any point. Okay? Okay, brilliant. Now, keeping your head still, I want you to just move your eyes to the direction that I tell you. So, to the left, to the right, to the left, to the right. Okay, and look up and down, up and down. Brilliant. Okay, now I'm just going to test some of the muscles in your face. So, can I get you to lift up your eyebrows and relax and screw your eyes nice and tightly and stop me opening them. Okay, puff out your cheeks. Okay, show me your teeth and clench them tightly. I'm just going to feel your muscles. Brilliant. If you open your mouth for me and stop me pushing them. Okay, now can you feel me touching you on both sides? And does that feel normal? Okay, can I get you to open your mouth for me? Okay, I'm just going to use the tongue. I'm not going to put it into the back of your throat, but I'm just going to have a look at you. Can you say ah for me?
Ah.
Okay, and can you stick your tongue out now? And can you wiggle it from side to side? Can you put it into your cheek? Stop me pushing you in. And to the other side. Stop me pushing you in. Okay, and now can I get you to look over to one side and stop me pushing and look over to the other side. Stop me pushing you. Okay. Try and shrug your shoulders. Stop me pushing you down. Okay, and relax. Now, any problems with your hearing at all?
No.
No. I'm just going to block off one of your earlobes. Can you hear that?
Yeah.
Okay. Can you hear that?
Yeah.
Okay. Fine. Thanks very much.
Thank you.
Okay, so obviously that was a super long cranial nerve exam. That's if you have a lot of time, but when we're doing skills, we'll also go over a great way to do a short cranial nerve exam. I just wanted to show you all the whole thing. So, also in their neurologic exam, we need to check and make sure they have motor skills. So, best thing to do, hold your hands out to your side, touch your nose, touch your nose. We want to document any involuntary movement, the quality of the movements that they do or any of the involuntary, the rate of their movements and their involuntary, rhythm and amplitude of both of those. We also want to know how they were posturing and what they were doing at the time we had them doing these motor skills. Also checking muscle strength. This is graded on a 1 to 5 scale. And it's going to be a ratio of the upper extremities to lower extremities. So they could have a 4/5. So 4 strength up top, 5 on the bottom. We want to check finger coordination. Check coordination altogether. Again, this is the finger to nose. You can also have them take their heel and move it along the shin of the opposite leg. If they're able to stand, ask them to, and also watch their gait or how they walk. And then proprioception. I had a video for this, but I didn't really like it. So basically what you're going to do is you're going to take the patient's big toe and show them up and down. So moving it towards them, being up, moving it away from them, being down. And then you're going to ask them to close their eyes and tell you which way it's going. So move it up, move it down. On our dermatomes, here is where the nerves going over dermatomes in A&P. So if they have a T10 fracture, we would expect all that green to be affected. So results of the neurologic exam. We want to know if they are having a delirium episode, which is a sudden acute onset, or a dementia episode, which is a little bit more chronic. Aphasia, difficulty speaking. Paresthesia, something's paralyzed. Now, on our unresponsive patients, for our secondary assessment, they're going to need a thorough head to toe. We cannot do a focused injury on these patients. We also want to make sure if it's not a trauma patient that we have them in the recovery position. We must have at least 2 set of vitals on these patients. And any unresponsive patient is always unstable. For our trauma patients, 2 different ways we can go here. If it's an isolated injury, we can just focus on that injury. But if they're multi-system, tab order, I swear. If they're multi-system, we require another full head-to-toe assessment. Be aware of those distracting injuries. While that open femur fracture looks really, really cool, that is not going to kill them right now. The fact they are not breathing is going to kill them. So be careful with those distracting injuries. Don't forget to do your rapid trauma exam and take those C-spine precautions. Infants and children, always attempt to get information from the child first. Now, if it's an infant, of course, you're not going to be able to do that. So most of the information here will come from the parents. On infants and children, it's better to assess from toe to head. So start at the bottom and work your way up. If you just go straight at a kid and start working on their head, you're going to freak them out. Look for any skin abnormalities. Check their soft spots and their eyes. Around the age of 4, start over. So have the family members hold the child if they're about 1 to 3, because they're not going to want to be separated from mom or dad. 4 to 5, these children will try and help with the exam. Above 5 should be engaging in the exam. If they're not doing that, then something's wrong. They're probably sick. On children, it's very, very important that we always remain calm and that we remain gentle. If we start to freak out, they're going to sense that and go with it. Do not ever lie to your patient. If you're going to start an IV, don't tell them it's not going to hurt. Once you do that, you lose trust altogether. So, recording findings. Use the same format every time. If you use a SOAP mnemonic, however you do it, make sure it's the same format every time. And be prepared for the handoff report. Nothing looks worse or makes you look more incompetent if you go in to the hospital and you have no idea. Like, be prepared for that. It's going to happen every time. The limitations of our secondary assessment. We don't have the same diagnostic tools as the hospital. Apparently that's our big one there. So, monitoring devices. ECG monitoring and 12-lead monitoring. I don't want to get too much into this. Cardiology is your next subject, and Leslie is so much better at it than I am. So, I'll let her do that. But on these, they must be properly placed. So, in skills, we're going to go over on how to place a 12-lead. This should be done on any complaint that may be cardiac. And just so you know, females are really weird. Females may be nausea and vomiting, and they're going to be considered cardiac. Carbon dioxide monitoring can be capnometry or capnography, waveforms, and numbers. Our basic blood chemistries, these are done in the lab. Usually these are on our transfer patients. Blood glucometer, this should be done as a routine vital sign. Every patient you come across should get you should get a blood sugar on. Our cardiac biomarkers, such as our CKMB or our troponin, these are also done in the lab, but some field versions are now available. Okay, so we have gone through our secondary medical, we've gone through our secondary trauma, and now we're at our reassessment. Here, repeat primary assessment, reassess the vital signs, reassess chief complaint, recheck your interventions, and identify, that does not say identify, and treat patient changes. So, while we're in class, are going to go over all of that again. However, this is the steps that we should be taking. I left out scene size up just because I like to use big fonts and I couldn't make it all fit. So, primary assessment, history taking, either secondary medical or secondary trauma, and our reassessment. That is it. That's all the time I'm going to take from y'all for chapter 13, and I'll see y'all in class.
My little Texas tornado blowing me away again. I swore it wouldn't happen again, but I looked at you and then I'm like a tumbleweed in a Wild West